Newly diagnosed myeloma is a very heterogeneous disease. We have very good data over decades now showing which cytogenetic abnormalities, which FISH abnormalities carry a high risk connotation to them. But there is still this group of patients that have functional high risk disease, which we are not able to pick up with our current testing modalities. The proportion of clonal plasma cells in the S phase has consistently been shown to be an important prognostic marker. We recently identified that when the clonal fraction is of more than 2% is in the S phase, these patients tend to have markedly inferior prognosis. The median overall survival for this cohort was around 4 years compared to 9 years in patients where the S phase was less than 2%. What was really interesting, though, was even within high risk and ultra high risk subgroups like deletion 17p, two or more high risk cytogenetics, 1q alterations, a high S phase still was able to identify patients that performed worse. We also looked at the utility of an elevated S phase in patients who had data available for the new IMS-IMWG high-risk consensus stratification. And what we identified was even in patients with an IMS high-risk designation, if your S phase was low, your survival outcome was actually fairly comparable to that of patients who did not have an elevated S phase. And at the same time, if you had both the IMS, IMWG high risk designation along with an elevated S phase, the median survival was close to 3 years. So we feel that there is a utility for assessing the fraction of clonal plasma cells in the S phase, and this can further refine the way we identify high risk patients. This is going to be especially important as we transition into an era of risk adapted therapy to have these nimble tools that we can assess fairly easily as part of our routine flow cytometry workup at diagnosis to give us a better idea of which patients might need more risk adapted therapy there.